avec les conférenciers invités que je vais présenter en anglais, puisque c'est quelqu'un qui va présenter sa conférence. We are very pleased to welcome Professor Yamamoto from the University of Tokyo, who is our primary speaker this morning. A few words on his bio. Professor Yamamoto graduated from the University of Tokyo, where he received his bachelor's, master's, PhD. He did a postdoc with the University of Canada. And since 1993, is faculty at the University of Tokyo and is now currently professor. In terms of scientific contribution, Yamamoto has been involved for quite some time in biomedical signal processing, in nonlinear statistical biodynamics, and also for health informatics. He's one of the several scholars worldwide who tries to bridge between data and signals on one side and human health and physiology on the other side. He has published more than 130 papers in different journals, has received several awards, including the New Investigator Award from the American College of Sports Medicine, and he sits on several other boards, including actually transaction biological engineering, the flagship journal of actually engineering, medicine, and biology society. The society which is dear to my heart, as you know. Today he will address multi-scale analysis of intensive longitudinal signals. It's not exactly big data, but it's somewhat related. And he will also address some clinical applications, including heart rate, variability, and spontaneous physical activity. Yoshi, please.
Yeah. Well, good morning, ladies and gentlemen. Thank you, Professor Liu, for a very kind introduction. And I'd like to express sincere gratitude to organizer, especially Professor Avery, for inviting me to talk in such a wonderful setting. And today I will introduce a topic on which we are currently writing a review paper with Patrice, that is multi-scale analysis of biomedical signals and its clinical application, particularly focusing on the so-called intensive longitudinal data, which stands for things like long-term personal health records obtained in daily life. So here is Leon, and what I'd like to do today is to think about physiology in the real world, in the era of Apple Watch and with the modern signal processing. And here is the outline. First, I will introduce what the intensive longitudinal data, or ILD, is, and a brief overview of what has been found in multi-scale analysis of two typical ILD, which is heart rate variability and spontaneous physical activity. They now mention about a unique proposal to study the so-called dynamical disease through analysis of biomedical ILD. And section 2 and 3 are the detail, and they will be followed by the summary. In the last few years, a number of wearable devices and cloud services using them for healthcare management have been released. And the development of such a technology allows us to obtain large-scale data by longitudinal design, but methods to analyze this kind of data collected continuously in daily life have not been fully established yet, and those characterizing signal features and related to underlying physiology and clinical events occurring on multiple timescales are required. The term ILD was coined almost a decade ago by behavioral medicine researcher describing repeated records of electronic diary for physical symptoms and mood and psychosocial environment and so on. This data had traditionally been collected by a single questionnaire, so they call this diary version ILD if the number of records exceeds, say, 50 times. In this sense, these are not really a big data, but more like a long-term personal record. This book also argued the future direction of ILD at that time, including dynamical analysis and modeling, and more rigorous automatic collection of biomedical data using wearable and or ambient sensor device technology, potentially generating really big data, which is now becoming a reality. For example, these are various physiological and psychobehavioral ILD that we are studying in the lab and continuously obtained from healthy people and a range of patients with heart failure, diabetes, chronic fatigue pain, sleep problem, and depression. The multi-scale analysis is really needed because timescales are so diverse, ranging from the order of seconds to that of days. Among these, practically only heart rate variability and spontaneous physical activity can rigorously be collected by the currently available wearable device. So in my talk today, I will introduce statistical and dynamical characterization of HRV and SPA as a typical ILD with multiple time scales of seconds, minutes, hours, and even days or months in the case of SPA. These data these data indeed contains a great amount of fluctuations known to show characteristics unique to various multi-scale complex systems, including fractality, multifractality, non-Gaussian and non-Poissonian behavior, and intermittency. These last two features are primary topics of my talk today. From a biomedical perspective, the massive existence of signal components exhibiting such multi-scale complexity is considered important for two reasons. The reason number one is that these fluctuations are considered to be generated unconsciously and independently of specific behavior of patients. Now I will show you later such an experimental demonstration for this. Thus, they're considered to provide robust measures reflecting intrinsic control systems, although these measures do change in pathological states like myocardial infarction, heart failure for HRV, and major depression and schizophrenia for SPA. The second reason is that beyond such healthy versus sick group comparison, which most studies have conducted, it may be possible to study disease dynamics through analysis of multi-scale fluctuation provided by ILD. Let us see this point for more details. The importance of studying statistical and dynamical feature of fluctuation can be understood by using this schematic view of the dynamics of physiological regulation and the transition to the so-called dynamical disease. This concept was coined by McKee and Grass more than a couple of decades ago, describing a quantitative transition or bifurcation to a disease state through a change in control parameters. Here is a famous example of bifurcation of the model dynamics of the white blood cell to pathological oscillations based on the nonlinear delay differential equation, or called McKee-Grass equation. Traditionally, physiological regulation have been explained using a concept of homeostasis, that is stability through constancy, coined by Cannon in 1930, but as you know, stemmed from the medial anterior by sensing its maintain a constancy in the vital variable, in this example, blood pressure, and by sensing its deviation from set point and provide a feedback to correct the error. A short-range negative correlation of state variable are expected in such a case. In 1988, the Sterling and Oyer extended this concept of homeostasis to that of allostasis, that is stability through changes, to account for the ability to adapt successfully to the challenge of daily life by the brain's mechanism to maintain viability, and emphasizing the complex biological imperative that an organism must vary all the parameters of its milieu interior and match them appropriately to the environmental demands. In this allostatic state, the spatial-temporal complexity of the control system may give rise to a multi-scale complexity in the state variable, and in fact, it has been shown that both HRV and SPA exhibit long-range correlation and intermittent dynamics only in the daily life condition, not, for example, during rest and non-REM sleep. While allostasis is necessary to make physiological regulation during daily life, further and sustained activation of this state may bring a system to a transition point to disease state called allostatic load. McEwen argued that this transition is indeed multifactorial, involving metabolic, cardiovascular, immune, and nervous functions and systems, but there are primary neurohumoral mediators, including hyperactivity of the sympathetic nervous system. This importance of sympathetic nervous system on the allostatic transition will be described later in my talk. Then here is a proposal. While the concept of dynamical disease is intuitively useful in disease forecasting, prevention, and control, the verification has been difficult because it requires large amount of data for the state variable to gain quantitative insight into the dynamical state of the system. Now it may be possible by using biomedical ILD to quantitatively study the dynamical disease through multi-scale analysis of the fluctuation as a probe for the underlying, in most cases, high-dimensional system. The introduction so far contains virtually all the primary messages, and in the rest of my talk I will show how these concepts are applicable for HRV and SPA. Hope this will be reasonably successful. So, heart rate variability. First, I will talk about the physiological background, a brief history of research, and unsolved problems and limitations. Then I will introduce studies on the characterization of multiscale dynamics, mainly focus on non-Gaussian and intermittent behavior in HRV, and of course its clinical application. This is a measurement. All the data used in the study in my talk were collected by this type of ambulatory electrocardiogram device called the Holter ECG monitor. While the primary purpose of this test is the detection or diagnosis of arrhythmias or transient myocardial ischemia, we here analyze a sequence of intervals between normal beats, and similar non-medical device, sensor device, and even a pulse rate device are becoming more and more available recently. Here is the definition. Beat-to-beat fluctuation of heart rate, or reciprocal of interbeat intervals measured as an R2R interval of the electrocardiogram, is called heart rate variability, or HRV. We usually just plot the interbeat intervals sequence like this, but sometimes for hundreds of thousands of beats for a day. Physiologically, this variability is under intricate autonomic control of the central nervous system through a sympathetic nervous system, SNS, accelerating heart rate, and the parasympathetic nervous system, PNS, decelerating heart rate, acting on the pacemaking cells of the heart. Is that true? Yes. A study on a patient underwent heart transplantation revealed that the transplanted heart without any connections of the autonomic nervous system displayed very little variability in the heart rhythm. By the way, this study was conducted in Lyon when my boss was doing a sabbatical here, and I was his postdoc helping analyzing this data. Although the lack of HRV might have worked for this gentleman to find the isochronism of pendulum, generally speaking, the reduced HRV is considered not so good in cardiology. This is a seminal paper by Krieger et al. Showing that the reduced standard deviation of HRV to less than 50 milliseconds dramatically increase the mortality rate of the patient after acute myocardial infarction or AMI during the follow-up period of 4 years. After this paper, HRV measured by the Holter monitor and has been frequently used for the purpose of risk stratification of cardiac patients. While the standard deviation reflects the overall variability, the next step was to decompose HRV in the frequency domain using power spectrum. Usually, frequency components are categorized into long-term and short-term HRV, and the former include ultra-low frequency components of each period is longer than about 6 minutes, and the very low frequency components are longer than 25 seconds according to the standardization task force by the cardiologist, and both rather aperiodic. The short-term component consists of rather periodic low-frequency component of which period is shorter than 25 seconds, and the high-frequency component shorter than 6.7 seconds. Let's look into the detail of each of them and underlying physiology for some of them. Historically, the high-frequency and low-frequency components of short-term HRV have been rigorously studied in the cardiovascular autonomic physiology as reflecting respectively the effect of the respiration and blood pressure oscillation on heart rate variability. Although you can see, here is the example of the bandpass filtered HF and LF components. Although you can see the sustained oscillation in HF, but in LF is relatively intermittent. And this has an important implication in later part of my talk. Okay. Physiologically, the amplitude of respiratory oscillation of HRV, or the so-called respiratory sinus arrhythmia. By the way, sinus arrhythmia stands for rhythmic modulation of normal beats. It's known to be primarily mediated by the parasympathetic nervous system activity, as shown by the graded decrease in amplitude by the increasing dose of the PMS blocker called atropine. Thus, for the non-invasive assessment of the autonomic nervous system, which is very important because the direct measurement in humans is quite difficult, and the power of the high-frequency power and high-frequency component is usually taken as a marker for cardiac parasympathetic activity. In low frequency, there is an oscillation in blood pressure control system called Mayer wave, due partly to the large loop delay in the sympathetic effector responses. The HRV caused by this oscillation is thus sometimes used as a marker for cardiac sympathetic activity, while it is well known the Mayer wave sinus arrhythmia, MWSA, is mediated not only by SNS, but also by PNS. As already introduced, the sympathetic nervous system plays an important role for a transition to the so-called allostatic load. Thus, finding non-invasive markers for SNS activity is very particularly important. Unfortunately, however, the use of low frequency, use of a low frequency or low LF to HF ratio, or sometimes called relative sympathetic predominance, and have not been successful. And this is thought to be one of the major limitations of the HRV research. They actually, in addition to experimental studies, clinical observation indicated the patients with elevated SNS have a decreased, not increased, LF power and LF over HF ratio. We will get back to this point later in this section. For long-term HRV, in 1982, Kobayashi and Musha published a seminal paper on the so-called one-over fluctuation in HRV. They studied long-term heart rate variability up to 2.5 hours, or about 10,000 beats of human in a quiet condition, and found a systematic one-over scaling or low frequency or long-range correlation up to about a minute. As this one-over fluctuation is known to be one of the hallmarks of complex systems, since then, HRV has become a benchmark data for study of nonlinear dynamics and biological complexity. One of the frequent concerns expressed by physiologists looking at this kind of result is whether the long-term heart rate variability might be due to non-stationarity in real-world monitoring, because behavioral episodes easily affect heart rate. Although we believe that the statistics obtained from about hundreds of thousands of data points can unlikely be modified continuously or intentionally, this is still a relevant question. So we studied this issue by conducting a so-called constant routine experiment. This is a technique used in the human chronobiology research, in which the behavioral modifiers of physiological variable was maximally suppressed to examine intrinsic, usually circadian rhythm. In the experiment, the subject stayed awake for 24 hours in a thermoneutral room and sitting on a comfortable chair, sitting on the comfortable chairs and ate small meals every 2 hours to minimize the effect of big meals, etc. And judging from the clean circadian body temperature rhythm obtained in the experiment seems to be successful. Then what happened on HRV? Interestingly, the one-over power spectra of HRV are unaffected by the constant routine up to large scale of about 1 hour or 4,000 beats. In other words, behaviors which might be contained in a daily routine do not affect intrinsic one-over scaling. And the same is also true for the body temperature collected, circadian-free heart rate fluctuation. So perhaps we can safely study the intrinsic complexity structure of long-term HRV, also including a multifractality and non-Gaussian behavior, up to this crossover point. But this is what is known for fractal or one-over scaling properties of HRV. The exponent beta is close to 1.0 in young people, but with increase with aging. An increased beta to greater than 1.5 is associated with increasing mortality risk in cardiac patients. As for a mechanism, analogy with the critical phenomena have been proposed, which I'll briefly talk about later. Beyond one-over scaling, as some of you might know, Ivanov et al. In 1999 found that in healthy individuals, scaling exponent calculated locally fluctuate considerably. That is, the fractal indices or Helder exponent have a sort of a wide distribution, and this multifractality is lost in heart failure patients. Although this kind of health disease comparison and doesn't tell much about the diagnosis because, for example, this is a comparison between healthy young and sick elderly. Finding such a unique spatial temporal structure stimulated further research on the quest for the mechanism of intrinsic complexity of HRV. One of such attempts is an analogy with the hydrodynamic turbulence, which was initially proposed by Lin and Hewson, again my boss. More specifically, they suggested a log-normal cascade model of fully developed turbulence known to generate multifractal, intermittent, non-Gaussian fluctuations. It can be used to characterize the complexity of healthy HRV. Well, this is just an analogy, but further extension to multiplicative log-normal model has actually shown to be fairly useful for quantitatively study the feature like a non-Gaussianity of HRV because we have a parametric expression of a probability density function beyond Gaussian, which is a log-normal distribution convolved with Gaussian kernel. Furthermore, this PDF by Castaigne has only one parameter, lambda, that controls the non-Gaussianity of a fluctuation. Having a parameters to describe non-Gaussianity quantitatively is a good thing, but the problem also arises when reducing a log-normal cascade to the multiplicative log-normal model. This slide shows such a problem that the multiplicative log-normal model can also generate, in this IID case, non-homogeneous, non-intermittent, non-multifractal noise. To discriminate these two, multiscale probability density function is useful. In this analysis, we consider partial sum of random variable x over a wide range of number of sums, or the scale S. For the IID process, the PDF of this sum rapidly approached to Gaussian with increasing scale due to the central limit theorem. And the non-Gaussian index lambda squares approach to zero quite quickly. However, in the cascade model with intermittency, this is not a case, and converging speed to Gaussian converging speed to Gaussian PDF is considerably slow. Here's an application of to the actual HRV by my colleague Ken Kiyono. And the results were unexpected, but we felt them quite interesting. We studied standardized PDF of healthy daytime heart rate increments constructed from about 2 million beats and found very robust scale invariance in the shape of non-Gaussian PDF with almost constant lambda square. This phenomenon was also behaviorally independent as the constant routine data result in the same, constant routine data result in the same conclusions. The pattern is different from the slow convergence to Gaussian expected for the cascade model. So we concluded that the long-range temporal correlation like a 1 over f and the scale invariance of anomalous non-Gaussian PDF of healthy HRV is reminiscent of critical state-like dynamics rather than the turbulence picture. As a related study, we further conducted a small experiment where 7 healthy subjects were monitored for HRV during forced prolonged period exercise with constantly higher heart rate or lower interbeat intervals, and during daily activity, B and D, and during sleep with lower heart rate. In other words, we changed a putative order parameter, that is heart rate, across the range contain a putative critical regime, that is a daily activity. And when we calculate the magnitude of log normal part of the multiplicative log normal model, and and examined the two-scale magnitude correlation across scale and time, the long-range correlation in magnitude or local energy was observed only in the daily activity. We guess the mechanism responsible for this kind of dynamic equilibrium underlies the allostatic state during daily activity. Indeed, there is an analogy of the allostatic state that it's like operating an air conditioner while opening a window. Then, what about intermittency? To our surprise, we rather found a systematic increase in lambda, mainly in the scales corresponding to low frequency and very low frequency range in patients with severe heart failure or congestive heart failure known to exhibit sympathetic hyperactivity, not in healthy individuals. Also, non-Gaussianity is higher in those who died after the test than those who survived. In this study, we evaluated the low-frequency non-Gaussianity at the scale of 40 beats. This approximately corresponds to 25 seconds, which is a boundary for low-frequency LF. And you can see the heart rate increments of the non-survivor displayed intermittent dynamics with the heavy tail distribution at this scale compared to the survivor. The lambda 40 was indeed an only significant mortality predictor in this population of congestive heart failure patients. In another study, we also showed that the increased non-Gaussianity of low-frequency HRV at the scale of 25 seconds was more observed in non-survivors than in survivors of acute myocardial infarction patients and predicted cardiac mortality independently from the other HRV measures, such as standard deviation, during the follow-up period of more than 2 years. In this study, we also showed that the patient taking the so-called beta blocker, a blocking drug for SNS, had a significantly lower average lambda 25 second than the other patients, implying that the increased non-Gaussianity of low-frequency HRV is related to overall sympathetic hyperactivity. Furthermore, we show that while HRV of heart failure patients show a cascade-like logarithmic decay in lambda square with increasing scale in the low frequency to very low frequency range with significant negative slope, that for the patient with neurological diseases such as multiple system atrophy or Parkinson's disease associated with the degeneration of sympathetic nervous system doesn't show such intermittent dynamics. So this result also supports the view that the presence of cascade-like intermittency with increased non-Gaussianity of HRV is compatible with the sympathetic hyperactivity. Let us try to interpret this result using a word of physiology. In low frequency and part of very low frequency, within a couple of minutes, heart rate dynamics reflect cardiovascular regulation by metabolic, chemical, hemodynamic, humoral, and thermal influences in addition to the aerodynamic factors. These subsystems are considered to be compensatory to each other. Therefore, it is likely that the only simultaneous failure of all these subsystems operating on a multiple time scale could result in the sympathetic overdrive, leading to the intermittent heart rate fluctuation with large deviation. In a time domain, it's like this. When at least one of the compensatory systems can suppress fluctuation, it's quiescent and laminar. Otherwise, sympathetic bursts occur. In fact, the band-pass low frequency and very low frequency power seems to display this kind of intermittency. Due to this intermittent nature of low frequency and very low frequency HRV, for example, standard spectral low frequency power requiring stationarity might have failed to capture this kind of a sympathetic burst. Instead, we would like to suggest that the low frequency non-Gaussian HRV could be used as an indicator for sympathetic activation, though this requires still further verification. Okay, here's a summary of the HRV part. It seems that the challenge of daily life brings the autonomic control system from a homeostatic to allostatic regime, where intrinsic long-range scaling of HRV arises. And further sympathetic hyperactivity results in an increase in low-frequency intermittency or non-Gaussianity in HRV. The fact that HRV are non-surviving cardiac patients exhibiting stronger low-frequency intermittency than that of surviving patients would indicate a relationship between appearance of heart rate variability intermittency due to sympathetic overdrive as a control parameters and the pathological transition. This is the proposed dynamical disease scenario for the cardiovascular autonomic regulation, right? Now, let me move to the story for SPA. Here, I will introduce example of objective evaluation of psychiatric disease using SPA, easily assessed by a wearable device. The intermittency and non-Poissonian scaling variance are again shown to play an important role for characterizing affective disorders, including major depressive and bipolar disorders. In addition, I will introduce an example showing that the multi-scale analysis of ILD could be used for early detection of ongoing changes in the pathological state based on the theory of critical phase transition seen in a wide variety of complex systems. The essence of our studies in this topic is nicely summarized by the coverage of an early article by The Economist. We indeed found that depressed people move mathematically different way from the healthy people. Physical activity can be continuously monitored in a quantitative and non-invasive way. For example, through the use of wristwatch type or band type acceleration sensors. This type of device has a capability of detecting small changes in bodily or wrist acceleration so that even slight movement by the subject is registered. Therefore, the data including rich information on conscious and in most cases unconscious behavior in daily life. We thus call this type of longitudinal behavioral data spontaneous physical activity, or SPA. This movie plays 100 times faster, show how the SPA data, the sequence of zero crossing counts per minute are generated. And then, if we look at the SPA data for 3 days and the daytime and enlarged version for a healthy individual and a patient with major depressive disorder, or MDD, you can see that the SPA of healthy people is characterized by clear circadian rhythm and the daytime sustained activity. In contrast, in the MDD patients, the circadian rhythm is much disrupted, and the daytime activity is characterized by increased intermittent burst. And the idea is to quantify the degree of intermittency as an objective biomarker for depression by looking at the distribution of period with lower activity or laminar phase. In practice, we converted the data into the thresholded binary sequence composed of the active and resting period defined by the period in which the activity counts are successively higher and lower than the threshold value, respectively. Then we examine how the distribution of resting period for the patient differ from that for healthy controls. By the way, the robustness of the results against the choice of threshold was checked separately in this paper, so which I'm not going in detail. In the first study by my colleague, Toru Nakamura, the SPA was monitored for more than a week or over 10,000 data points in 14 MDD patients and 11 age-matched healthy control. As you can see, the cumulative resting period distribution or lifetime distribution of the period of lower activity take a power of form, a straight line on the log plot, and not an exponential form expected from Poissonian waiting time distribution for the onset of activity. And interestingly, the power law exponent gamma was significantly smaller in patients than in patients than healthy controls. This implies that there were statistically and systematically more frequent episodes of longer rest within 10 to 100 minutes in the patients. This difference is visually shown by these barcodes representing the sequence of resting periods. So it seems that the exponent gamma could provide an objective measure for immobility associated with depressive mood. Next question we posed is how animals move, and through such studies, how to interpret the increased SPA intermittency in depression. Mental or cognitive brain function and the abnormal psychiatric disease, including depression, are still difficult to approach through the biological techniques. There are multiple reasons, but it is partly because no objective examination method for their diagnosis, such as blood tests and brain imaging, are used clinically even in humans. One idea is that our objective biomarker, gamma, found in humans may be useful in establishing animal models for affective disorders and facilitating the underlying and understanding their pathophysiology. So we try to do the same analysis as done for humans for SPA of mice. In this experiment, a high sensitivity and high resolution acceleration signal of free-moving mouse was obtained by a sensor sheet placed under the cage and for 3 days, and the local variance or energy time series was constructed as a surrogate for human SPA. Then the resting period distribution of 12 wild type, perhaps healthy mice, and 9 mutant mice in their circadian clock gene called period 2 were studied, partly because circadian abnormality is known to be associated with depression. This left panel is what we have already seen for humans. And first, we found that while the average resting period of mice is about 100 times shorter than those in humans, the rescaled lifetime distribution for wild-type mice was almost identical to that for healthy humans without significant difference in gamma, thus showing a sort of a universality. This is quite interesting because it means that if you are monitored for a number of days by, for example, sensors embedded in your house and pray that record 100 times faster, and that is exactly how mice start moving within a minute, like a movie that I have already shown you. The second, among other clock gene mutant mice explained in a different paper, examined in a different paper, only per 2 mutant mice share the decreased gamma or increased SPA intermittency with human MDD. So the mechanism may be related to what's happened in PAR2 mutant mice. Our German colleague actually indeed let us know that their PAR2 mutant show the alteration in the glutamatergic system and increased preference for alcohol and drug abuse related behavior and treatment with the receptor antagonist reduced the excessive alcohol consumption behaviors. As these findings suggest the alteration in reinforcement or reward system in the brain, we tried to study whether the model describing a sequence of choice for actions based on the priority or preference could account for the increased intermittency seen in depression. The model is based on 3 assumptions. The first, spontaneous movement in animals and humans would be triggered by continuously presented internal or external demands or stimuli like appetite and emotion and so on. Second, on the basis of their biological importance, one demand stimulus is probabilistically chosen to make action either consciously or unconsciously. And finally, once the action is taken, then the list is refilled randomly. Resting periods are, of course, those when any actions are not taken successively. With this model, we demonstrated that the strategy where each demand stimulus is probabilistically chosen every time in proportional to its biological importance can explain the statistical distribution corresponding to the healthy case and simulate healthy barcodes based on the theoretical waiting time distribution. In contrast, the decrease of gamma observed in depression can be reproduced by assuming this lambda greater than unity in this case. This assumption implies that the demand stimulus with only higher priority, like alcohol for PAR2 mice, is preferentially selected, giving rise to the fatter distribution tail and frequent episode of longer post-resting period, generating a more intermittent sequence of onset of activity burst. Although not going into the detail, the resting period of a patient in a manic phase of bipolar disorder can also be explained by this model actually. Thus, we suggest that this is one of plausible models that can explain relationship between mood and behavioral alteration in affective disorders. In the last part of my talk, I will introduce our study on the bipolar disorder using ILD. Now, this is a kind of topic for which we really need ILD. Bipolar disorder is a major psychiatric disorder demonstrating recurrent and alternating period of manic or hypomanic, depressive, and mixed episode with varying intervals. And this slide shows a series of 2-day plots of black active and white resting or sleeping period shifted every day. We call this a double plot for a patient for almost 1 year. This patient was also asked to score his mood every night from the worst to the best. And you can see that a kind of a clinical phase transition around 150 days. The question is whether this phase transition could be captured by analysis of SPA and early detection of the pathological state like this. Pathological state change could be that possible. The continuous nature of SPA allows us to evaluate the daily change in gamma in a continuous fashion. The values of gamma were lower in a depressive state than a hypomanic state. And the low frequency fluctuation of gamma demonstrated that the significant concurrent association with self-reported mood scores. This indicates the possibility of quantitatively and continuously capture manic depressive phase transition from SPA monitored using wearable device. The next question is whether these high-frequency ILD can be used for early detection of the transition. We based on a generic framework of critical phase transition in various complex systems ranging from cell signaling to economics and to climate systems. For example, critical slowing down is known as a characteristic dynamic phenomena emerging in the vicinity of the phase transition or a critical point. The systems showing critical slowing down are theoretically characterized by a decreased rate of recovery from small perturbation, and which result in the accumulation of persistence of perturbation over time, leading to increased local variance and also autocorrelation around the critical point. When we calculate the autocorrelation coefficient for the gamma curve within a sliding window of size of 10 days, it was shown that during the transition period from depressive to manic phase during 130 to 50 days, the autocorrelation coefficient gradually increased toward 1.0, possibly giving rise to the early warning sign for the phase transition. On the other hand, during a clinically stable state of depression and mania, and the decrease of correlation coefficient to around 0 was observed. And this example suggested the possibility of detection of early warning sign for pathological transition by evaluating the dynamical feature of SPA and also the ability of utilizing biomedical ILD to empirically study disease dynamics. Here's a summary of the SPA part. Even in healthy cases, our behavioral dynamics during daily life is characterized by non-Poissonian, power-law resting period distribution, and the further increase in intermittency was observed in major depression, with slower day-to-day variability in bipolar disorders. That will be followed by the state changes, but with the reversible potential shape in the case of bipolar disorder. And this is the proposed dynamical disease scenario for behavioral alteration in affective disorders. Finally, this is a sort of a take-off messages. It's a time to start thinking about the rigorous use of biomedical ILD for new types of ambient diagnostic and prognostic tool, and for disease focusing, prevention and control. For that purpose, multi-scale analysis is a useful tool to extract information on clinical events occurring on multiple time scales